And lots of times when you touch that spot, the patient will say, man, that's sore. I didn't realize that I never have any pain there. Why? Well, you don't have a lot of proprioceptors in these areas, pain receptors, but when you touch it, man, it gets their attention. So now we're at about the spine of the scapula. That's going to be about 3. So we get our thumbs in there and sit up good and straight, stomach forward, shoulders back, and that's symmetrical as anything. Now slump down and lean back. And when he does that, right at the end, that left thumb comes back. So what's our diagnosis? We're seeing an inflection, so that means we don't have symmetry inflection. So it's got to be, it's named ERS. Then which thumb is coming back at you, the left side, so it'd be ERS left. Okay. So I could treat that like this again. I could come over, let's do it this way this time. See, and again, I like to have the patient rest against me because then they can, see, look, if I do this, I have trouble localizing my forces. If I let him just rest against me a little bit, man, I can get a lot better localization. And I've had females say, well, I don't feel comfortable having males rest against me like that. Just get a thin pillow, put it between you and the patient. I had a resident last year that did that. She just loved it. So let's have you push to the left.
The pillow or
The what?
the pillow or the treatments like that?
Yeah.
You could put an S on it,
No.
I guess, for like super shield.
She just felt so much. She felt so much more comfortable. Now push her to the left. And what was neat was she was Mayo Clinic signed her up to come there before she ever came to Pikeville. Now push left. So she's at Mayo Clinic now doing her thing with another one that I trained 3 years ago. Oh. Can you feel the difference in
I didn't know there was a problem there.
there?
That was a good name.
But, now, remember what we were saying, say if we had an FRS right, now all the extended ones, see, and a lot of people say you can't use the head to get down to below 5. But if I palpate L5, now lean against me and slump down. And if I get that at the apex of the curve right there, I can side bend his head, I can rotate his head. I'm changing L5. So if you use translation and get it at the apex of the curve, you can use the neck all the way down. So if any of the thoracic ones that are extended from T1 to T12, you can treat those all in one step. If you have a flexed one from T1 to T5, you can do it all in one step. It's when you get like 6 to 11, a lot of times it's hard to get them into extension because of the kyphosis. So say if we had one down here at 10 that was FRS right, then why can't I use type 2 mechanics inflection to reverse the side bending and rotation? And then once I get that out, say now sit up good and straight, stomach forward, shoulders back. See, there would be the extension. And then have him push his head forward. And you're just doing it in 2 steps. But you're using, but see, if you try to memorize that as a technique, it can be wild. But if you say, no, I'm just going to use type 2 mechanics inflection, why can't I do that? To change the side bending and rotation. Then once I got that out, then it's easy to get the extension in. The body will let me do that. Whereas if I try to do all 3 of those initially, can't get the job done. Okay? Okay. So if there's an increased kyphosis, a lot of times if you try to extend them side bend, the body just won't let you do it. Okay? So then you say, okay, I can treat them in flexion. So how do I know I'm in a flex compartment? Because I have them slumped down, and if I side bend the head to the left, I can feel that vertebra rotate to the left too. Then I know I'm in type 2 mechanics, inflection. Okay? So then have them push their head to the right and do that 2 or 3 times. See, then you're changing the side bending and rotation component. Relax. Okay? And then once you've got that, all of it out, then say to keep the side bending and rotation, say sit up good and straight, stomach forward, shoulders back, and then when you bring them back, then it's so much easier for them to get into extension because you've corrected 2/3 of the dysfunction. Okay, make sense? Now, the last one, let's talk you through. This is usually a a lot of fun, but I think this technique changed my practice more than any one technique I ever learned. And what it is you frequently get flex dysfunctions at T12. And about 85% of them are gonna be flex side bent rotated left. And these are the people, man, they're like this and they walk into your office like this. They got a psoas spasm there and they're in a mess. And I hated to see those people coming. You know? And we're all wrestling with how do you treat those. And Fred Mitchell Jr. one time announced to us that he had a technique to fix it. That was the good news. The bad news was it was a 500-step technique. I mean, it was the craziest thing. And he never explained it the same twice. Nobody could get it to work. It was just ridiculous. And I went to this guy, Kimberly, and said, hey, what do you think of Fred Jr.'s new T12 technique? He said, it's a bunch of BS. He said, learn the principles and get it to work for you. And I said, what do you mean? He says, say if that is FRS left. Have you ever thought about using type 1 mechanics to reverse the rotation first? And why is T12 such a bugger? Because the upper facets, I think, are coronal. The lower are sagittal. Right? So think about, then what's the afferent input going into the cord from there? The upper facet pair is saying, we can flex and extend, we can side bend, and we can rotate. The lower ones are saying, you're crazy as heck. We can flex and extend. We can't side bend and we can't rotate. So when that gets dysfunctional, I think a lot of confusion goes into the cord. And what does the body have to do? What are the two options with muscles? Can either relax them or tighten them up. What does it usually do? Tightens them up. So then T12 is a real mess. See, and then because of that T12, they decrease their lumbar lordosis. And remember, what's the origin of the psoas? You guys ought to be able to rattle that right on. The lower half of T12, L1, 2, 3, 4, not 5. So what happens is the psoas can go into spasm. You can get flexion and side bending. L5 can become hypermobile because there's no attachment from the psoas. Then their chief complaint many times is lumbosacral pain with or without sciatica. And it's because they decrease the lordosis and they're getting a ton of shearing effect. The weight isn't evenly distributed between each vertebra when they have that normal lordosis. Okay. And so a lot of people then keep treating L5 and wonder why it keeps coming back. And you treat T12, which is totally asymptomatic, and get that working right. That restores the normal lordosis, takes the hypermobility out of L5, and less times they quiet right down. So think about it. If we've got a patient here that has FRS left, yeah. So picture that thing is FRS left, and so then where do we want to end up? ERS right, because it's that right pair of facets that won't close. Okay? So then Kimberly said, look at, palpate T12. You can palpate the rib with your finger. Then make sure they're in neutral, so sit up good and straight. And how do you know you're in neutral? Because they may look like they're in neutral, but they're not. But if I just gently side bend him to the left, and if I feel that thumb on the left side go anterior, that means T12 is rotating to the right. So side bending left, rotating right. That's type 1 mechanics. I know I'm in neutral mechanics, and I can take up the slack by rotating him to the right a little bit, up to the barrier. See, then what you're doing is you're using type 1 mechanics to rotate that whole region to the right, and if you have T12 at the apex, you're going to get the most rotation there. That's what you want. See, and then Kimberly said, what you're really doing is you're using the vertebra above and below to say to T12, come on, you can do it. In fact, we'll help you do it. We'll help you rotate to the right. And then, so then I'm going to have him push sideways to the right gently, then relax, then take up the slack he gives me again. Now watch. I've got him side bent left. I cannot side bend him right. I can jump on him. Why? Because he's in type 1 mechanics. So then Kimberly said, just keep a little pressure there, and have the patient say to him, slowly sit up good and straight, stomach forward and shoulders back. and look at, he automatically comes over and side bends right. See? Now, if I didn't understand those principles, I'm gonna be working like everything, trying to force him around. But what happened there? That as soon as he went from type 1 to type 2 mechanics, because T12 was rotated to the right, it had no other option but to side bend to the right. Okay. And then where have I ended up then? ERS right, then just have the patient side bend and rotate to the left, and that'd be the last part of that muscle energy effort. But once I learned that technique, man, I'd love to see those people come in. Because that's about the closest you'll see to a miracle. They'll walk in, all hunch over, and a lot of times they'll walk out and they're straight. Now, what else can this do? Where does the dermatome for T12 go? Right into the, above the inguinal ligament. So lots of times you're gonna have patients that have chronic lower right and lower left quadrant pain that nobody can figure out. And lots of times it's dermatomally related to T12. And lots of times, think about it, it can start in the back and can radiate around. What does that sound like? Renal. See, lots of times docs say, well, I think they're passing the kidney stone. Then they work them up and say, well, they're not passing the kidney stone. They're probably passing gravel. You know? And then they say, oh, you cured me my kidney stone with that technique. No, just took off the pressure off that T12 dermatome. And so that don't be surprised if some of the chronic lower left and lower right quadrant pains that nobody can figure out get better just by getting that area functioning right. So, see, and you can imagine, if I described that as a technique, it'd be 500 steps. But that's why I kept stressing principles, principles, principles. What's the first principle? We're gonna treat that, we're gonna use neutral mechanics, sit up a little straight. And see, and how you can actually do that is slump down a little bit. And if I side bend him to the left, my left thumb comes back. So what does that tell me? I'm in type 2 mechanics. But if I keep the side bend left and a little bit and say slowly sit up good and straight, keep going, keep going, keep going. And right there, my thumb went forward. I know I'm in type 1 mechanics. Okay? And I can confirm that because I can rotate him to the right a little bit. Whereas drop down just a little bit. Right there, see, I can't rotate him to the right. So slowly sit up good and straight, and right there. So now I'm using type 1 mechanics to get everything to rotate to the right. Which vertebra are we trying to treat? 12, then you make sure that one's at the apex of the curve. And then you're using all the vertebrae above and below it to re-educate that thing, which I think is just so neat. And then watch, when I have him in neutral, see, I can't side bend him. But if I then say, now, I just got about 1/10 the pressure, not even that, less than that, and just keep a little pressure there and say, now slowly push your stomach forward and bring your shoulders back. Keep going. See, and right there, he started to side bend to the right. Why? Because he had to. See, now I've got the principles working for me. See, because if I get T12 rotated to the right, and I get him in non-neutral mechanics and extension, he's got to side bend to the right. His body can't do anything else. See, so then that way you don't have to work hard, and it's neat. You're just talking the patient through it, and then you're getting paid. But see, if you try to memorize that as a technique, you get about the 4th step and you don't remember it, you'll never use the technique. But if you say, initially I'm going to use type 1 mechanics to get the rotation, then once I get that, then I'm going to go into type 2 mechanics, and because I got the rotation, I'm going to have the side bending, I ended up where I want to be. See, then you can picture that in your mind, then the technique just flows out of that. Okay?
I want to emphasize too, as you watched Ed